it doesn't want to load, I can just run the slides for you, Adam. And just let me know when to move forward.
Okay, I will. I'll do this.
I think maybe say next slide just in case.
I will.
I think
Yeah,
you're kidding, but just in case.
I will.
Just in case we all get mesmerized by the slides. Just for the group, you may all know Dr. Murphy, but if you don't, he's an assistant professor of urology and also preventive medicine. He's an expert in an expert trialist and in biomarkers. He's had multiple trials that have been successful in recruiting minority populations, and that's obviously important for so many reasons, but certainly a focus of our group and of the NCI. And so we thought we would take the opportunity, and gracious enough to give us the chance to talk to us a little bit about how he's been successful at doing that, some of the barriers, strategies, and other things that he's worked on. I think just for the sake of the audience, let's just give them 1 more minute, and then you can please go ahead, Dr. Murphy. And thanks again for sharing your time with us.
No problem. Thank you for the invitation. A lot of people in the room actually have helped me do this, so it's actually kind of funny to be talking to my group.
Dr. Murphy, do you want me to run the slides for you?
Yeah, because it never actually stopped doing the spinning wheel of death.
Can you see them here?
I can.
Perfect.
All right, great. Well, I think we can go ahead and get started. People may straggle in, but go ahead and get started. We'll put in the chat the code to text if people want to claim CME.
Okay. All right. Can you make it full screen, Mary Kate, or maybe a little bit bigger? I don't know if that's possible. Okay, cool. It's a PDF. All right, well, good evening. I'm Adam Murphy, and most of you actually know me, and many of you have helped me along the way, actually, in doing this work. Basically, I am kind of half urologist, have clinical researcher focused on prostate cancer disparities. And I got the fortune of working with Dr. Bill Catalona and Dr. Rick Kittles on my initial research that got me a Physician Research Training Award. And I had the time to basically do a 2-week NIH kind of health disparities boot camp down at Meharry in Nashville. And I've been using a lot of that information I got from that and some of the experiences I've got at Northwestern and in the city of Chicago to become fairly proficient at doing this work. So next slide. This is from the NCI's cancer.gov page. They actually spotlighted the research we did, which was the first time for me doing this. We had a completely all African-American team of researchers and research coordinators. We basically did a validation of prostate health index in African-Americans. We recruited 140 African-American healthy controls from the community using the social network of 8 lay African-American men. And we trained them to be city trained. We actually trained them to be research coordinators, and they used snowball technique to essentially recruit 140 men in 9 months from the community, from their social networks. And so it was we had a multi-PI team. This was funded by Melissa Simon's Chicago Check grant as a pilot study, a 2-year pilot. And so it got paired with funding from the V Foundation to do clinical validation in a biopsy cohort recruited at Northwestern, Cook County Health, and University of Illinois Chicago. But we also did this community arm, which is what's focused on the NCI website. So I basically have this kind of split role where I am a researcher at Northwestern. I have a lab at the VA, but I also work clinically at the VA and for the Cook County Health System, working mostly at Providence Hospital, but a little bit at Cook County Stroger Hospital. Next. This is how I got my start, and the reason why I feature this is because of the fact that it was a simple study. It was essentially people went and got prostate biopsies. Our coordinators would get to them right before the biopsy, draw their blood, ask a few short surveys, and then the patients would be done. And Dr. Catalona is on this paper as my senior mentor, and Rick Kittles is my secondary mentor for this. This was one of the outputs of my DoD Research Training Award. Next slide. And the reason why I highlight this paper is because we had, out of 667 participants, there were equal numbers of African Americans and whites. We turned European American for this study. We got 119 others, which are mostly Hispanics. What we were able to show was that vitamin D was associated with prostate biopsy outcomes, more so in African Americans than in whites, which show the importance of having a subgroup analysis take place, because we didn't actually find a strong effect on prostate cancer diagnosis in whites. It was only in the aggressiveness, having higher grade tumors in this group. Next. So this was me getting to the big leagues in a real clinical trial that had actually 4 patient visits, including 1 study visit that was not tied to a clinical visit. This was at UIC, this recruited at UIC, Cook County Health, and J.C. Brown VA. There was no recruitment actually at Northwestern on this study because there were 2 competing other studies at the time in the active surveillance space. One was on, I think, genetic predictors of active surveillance, maybe progression. And so we couldn't, it didn't make sense to do it. And it ended up being a really enriching experience because it was a first complicated clinical trial with multiple visits for me and really working with kind of a more difficult, complex study design. Okay, it was a simple randomized controlled trial using Oncotype DX. And I highlight this, the racial breakdown in red here because we had a cohort of active surveillance eligible men. There were 200 recruited and randomized. And 140 of those 200 men were African American. And 25 of them, or 12.5%, were Hispanic. So we exceeded kind of racial composition standards for clinical trials in this one. But it was strategic in where we recruited in this study a lot. So we got a veterans hospital, a county hospital, and another safety net at UIC. Next. So I think we all know the problem. I think in about 20 years ago, 1993, the NIH made this kind of act, revitalization act, to essentially require that investigators kind of make a plan to include women and ethnic minorities into the research that they were funding. And that really has not improved by much. Only about 2% of those, of 10,000 trials, actually met minority participation kind of goals. And of the ones that have been done, there were 782 randomized trials, and only 13.4% of them actually reported on race as out for their primary endpoints. So this is in contrast to actually what patients want. If you poll patients, it sounds like Hispanics are actually more willing than whites to enroll in clinical trials, and Blacks say that they would participate at equal rates as whites. So it's not the Tuskegee problem that people kind of really mentioned a lot. And although we have had some increase in African American enrollments, they're up to 15% of phase 1 clinical trials. It's only 4% in phase 3 trials. So it's not improved across, especially when you want to use these drugs in actual patients. It's not really, they're not well represented there. And there's been some issues with that, where 5FU caused a lot more leukopenia and thrombocytopenia in African Americans, and it wasn't discovered during the clinical trials phase when they were using it for lung cancer treatment. So what patients actually say is that they're not given access to clinical trials. And I guess that can be for multiple reasons. Some that have been named are that African Americans and Hispanics have more comorbidities, and so they're ineligible often, or they're uninsured, and there will be some out-of-pocket costs in some trials if they were not insured. And then I believe that physician time limits play into this, because if you believe a patient has a language barrier or health literacy barriers, it may take more time than we have in clinic sometimes to get folks enrolled. Next. So looking over multiple papers, I found that these are the key barriers that people kind of repeatedly pointed to. There were physician barriers, patient barriers, and kind of systemic higher level barriers. And so physicians kind of are viewed as a primary triager of patients, whether they would be someone a coordinator should talk to or not, or they should talk to. And also, physicians aren't always aware of the exclusion criteria or inclusion criteria, and may exclude patients unintentionally because of that. There are patient barriers. Theirs are fear of what's going to happen to them in the study, which, and then distrust in the medical community is often cited. I believe that those can be modified by talking to the patient about it, so they're more aware of what's going to happen to them on the study. And then also physicians could, I believe, in their own relationships with their patients, can modify a lot of the mistrust. So they may mistrust the entire community, but they may trust their individual physician. And then there's burdens associated with participating in the trial that we have to kind of ease for underserved populations. I also think that systemic barriers are really there. One big one was kind of outside hospitals, outside providers are nervous about sending their insured patients to Northwestern because they may keep their patients or poach them. And also sometimes people complain about wait times getting into the system. And then in general, with physician burnout kind of in the news a lot, and precision medicine making trials sometimes more complicated, where they have very, very rigorous designs where it alters based off of a biomarker or a biopsy result. And so there's more imaging involved or more biopsies involved. It's more cumbersome for the systems too. Next. Okay, so what are some good things? What are some facilitators of participation? What encourages people? I think physician enthusiasm, and that's well borne out in the literature. An excited doctor talking about the study is more motivating for the patients. Obviously, communicating well, a good relationship, having there be a perceived benefit, which I think is, we're supposed to present kind of equipoise about our research questions. But there's also this potential that this new agent or new intervention may improve your outcomes. So I guess it's a potential perceived benefit. And I think one that really does matter is people feeling altruistic about, this may not be helping you, but it may help your son, your grandson, or people like you in your community. But I think a lot of the literature is missing kind of a key point, that it's obvious, but it's never really mentioned in the literature. Next. Next slide. I think they're missing the coordinators. People forget that not everyone is comfortable talking to people outside of their own ethnic group or racial group. So that is seen by how people choose to select physicians. If they, it's true in who people befriend. It's true in who people sit next to in the lunchroom. That people tend to self-select or sort by different tribal groups: male, female, race, ethnicity, language. And so I think that one thing that we've worked on is really hiring coordinators that were willing to go out into the community with me and do outreach. And I tell people up front that I'm going to the South or West Side, or I'm focused on African Americans or Hispanics, or everybody, but that it's required that they interact with people from other groups. That part is something that I've had to be really intentional about, because if patients are saying they're not even being given access, and oftentimes coordinators are screening, I noticed initially that the rates of people who were being initially approached for the study were lower for the minorities than for the Caucasian patients. So we do biopsy tracking, where we see everyone who had a biopsy, how many of them were eligible, how many did the coordinator actually attempt to enroll, and then how many they got enrolled. Initially, the numbers of minorities that were attempted were lower. And I think that is about coordinator comfort. And so we had to do a lot of training of our coordinators, and we picked them to be multilingual, kind of naturally interested in diversity, willing to go into the community. The ones that already were kind of focused on social justice issues or picked my lab to apply to because of it was a plus. But even if they are interested, we still did a lot of training around cultural competence. Next. So I'm just going to detail some of the things that I think were important in the coordinated training. We taught about systemic racism before it was a thing, to kind of say naturally, because of the fact that people who they may be recruiting may have lower health literacy, or they may be more distrustful, and not to be offended by that level of skepticism that a patient may present them with. I did this research for my wife when she was applying for her job at Adler University, and we basically had to figure out what were the issues around minority retention in the faculty and in the grad school there. And what we found out was that Blacks and Hispanics had more stressful events that would occur over the course of 1 year. So, it could be a divorce or a car accident, or someone in the family was ill. They tallied those up for a bunch of grad students, about 100 grad students over a year in each racial category, and found that on average, whites had about 4 stressful life events a year, Hispanics had about 6, and African Americans had about 8 in the average year. And so those stressful events would oftentimes take people out of the grad school program, or the grades would suffer as a result. And so just trying to make research easier, given that these stressors are happening more often, was something that I had to remind my coordinators about. And making them know that research may look like a lower priority in the lives of your minority patients. And they also have increased barriers to care with insurance and language barriers. And so I thought it was our responsibility as researchers to help them reduce that burden. And so that's kind of how a lot of the suggestions come along. Next. So when I interviewed my coordinators, I specifically asked about their comfort in other settings. I kind of told them that we would do it in safe spaces, but that we are really having a lot of community events on the west side of Chicago at a church on a Sunday. And you may be the only person of your race in that setting. And the people who, I guess, enlist are the people who really made the lab work out so well. So I screened actually for some passion around social justice or equity, and I purposely diversified my team around the languages that I wanted to recruit into the study. Next. So this was just on the right, talking about the number of stressful events that were happening by race during the COVID-19 crisis. And you can see Blacks and Hispanics at the bottom as the darker blue color. I'm sorry, middle blue and kind of darker blue are Black, Hispanic, and other race. And you can see that the Blacks, Hispanics, and other racial groups had higher levels of social determinants of health stressors happen during the COVID-19 crisis. And I think that's just driving home the point about the importance of coordinators lowering the barriers for a lot of these access issues with the patients. So the coordinators were trained as patient navigators. There was a patient navigation boot camp at UIC that several of my coordinators did for the U54 validation of prostate health index. They would give reminder calls 2-3 days before an appointment or an MRI, for example, to make sure that they got there. If they had to reschedule their appointment because something came up, they would work with the clinic schedulers and the physicians to allow for them to be seen still within the framework of the study. And sometimes we have to bounce other people back or overbook a clinic to make sure that they made it in. And if they got there, we would have the patients meet with the coordinators early, so when they're waiting, they would get surveys and blood draw and things like that done, so that the waiting wasn't just in the lobby. We oftentimes worked with federally qualified health centers in Cook County to take people that we've screened in the community for elevated PSA. If we could not get them insurance because they didn't qualify for an Affordable Care Act plan, we would send them to one of the federally qualified health centers to set them up with a primary care doctor, or we would send them to a Miles Square Center, or I would see them myself at Cook County Health. And Northwestern often, several of the urologists, including Dr. Catalona, Meeks, Schaefer, have seen some of my community referrals too. But we wanted to have all around kind of safety nets for these people that we were recruiting. And we had to prepare our coordinator for these increased educational burdens, because oftentimes patients would be sitting there outside the biopsy clinic looking mortified, nervous. They didn't know what a prostate biopsy was, despite meeting with their urologist a week before or 2 weeks before. And so just teaching the coordinators what a biopsy is, what a radical prostatectomy is, what is active surveillance, sometimes they could actually allay some of the fears of the patients. And by improving their health literacy, they can make more informed decisions about their participation in the research. Next. So, as you know, we got our coordinators out there. In one summer, in 8 months, we recruited 140 African American men for the 5 validation study. And during that time, these coordinators are getting to improve their blood draw skills. They're getting to increase their comfort with minorities and other ethnic group men and families. And they're improving their spiel, because they have to do good salesmanship to recruit people in a mega health event where there's people having giveaways, there's shows on the stage. So I think it improved our coordinators' ability to kind of talk to people and sell the study a little bit. And then we always collected the names and emails and contact information for all these people who walked up to us for education purposes, because we could enroll them in other studies. That's one of the check boxes. Are you insured? And are you willing to be contacted for future research? And that helps us fill out folks for future events. And also provided a natural referral system for other studies when they had elevated PSA and came over to the clinics. Next. So I talked about the key barriers. Next, I'm going to talk about the solutions that I think that they exist. Next. So, for the physicians, trying to have the coordinators pre-screen by going through the providers' schedules for the day, seeing who's eligible, and reminding the providers about it kind of eliminates the physicians kind of trying to hold the inclusion and exclusion criteria in their head. And it also deals with some of the time issues that the physician has, so that they don't have to think about adding this patient to the study and grab a consent form and go through a spiel. They can hand them off to a coordinator. So the coordinator pre-screens, informs the provider that this person's eligible, this person's an ethnic minority, we need this number, and the physicians then can discuss the study with their patients if they have time, or just do a nice warm handoff to the coordinators. And then the other thing is, if it's about insurance or needing supplemental insurance, it's nice when at the other sites, like at UIC or at Cook County, these patients, because they need the insurance anyway, are oftentimes seeing the financial counselors. And if they need supplemental insurance to get through this treatment, they may be advised to do so. If they need to get on a charity care program, that's when that would happen, and it will allow for them to be on study oftentimes. And then I just think the physician knowledge part is just having coordinators around pre-screening to remind physicians when they're busy of the eligibility criteria, and also reminding them about what this study is about. So it's not just on the clinician. And then and also to highlight where we are in terms of accrual goals, like where are the urgent needs in terms of racial breakdowns and the people who've been enrolled so far. Next. In terms of the patient barriers, I think it's about really dealing with their trust and their fear, which is really interpersonal. So the fear, I think, is a bit of the coordinators and having study brochures that are available and allowing for patients to have the consent, take it home with them, discuss it with family, so that it's less of an acute issue and the coordinator can follow back up later by phone to kind of close the deal. I think physicians, by asking their patients and really just working on their relationship, that deals with a lot of the mistrust in the medical community. And then whatever we can do to kind of reduce the burdens of trial participation. So when I do my studies, I try and pair, as anyone does, as many of the in-person visits to urology visits as much as possible, and to make the appointment sometimes convenient, we will rearrange the appointments so that the patient can more certainly get there, or their ride can be there to bring them and take them home. We've also done a lot of providing venture cards and parking validation to patients. It often helps if the coordinators can have a space of theirs also aside in the clinic to bring patients before the appointment or after the appointment that doesn't interfere with clinic flows. And we oftentimes, because the coordinators call, will bring the patient in again to do the surveys and blood draws before they have to go to the clinic. Bring them in 45 minutes early. And we reserve money in the budget for Ubers and cab costs, and can even arrange medical transport for people who don't have help to go back home after a visit. Or they're later than their ride and they had to leave and we had to send them home a different way. So our coordinators are trained to do that. Next. So the systemic barriers are a little bit harder to overcome. I think things are getting harder for patients to be involved because there's a lot more kind of tissue and specimen collection, and there's a lot of imaging now, which it's great to increase, but it means that oftentimes patients have to come back additional times, and so it can be burdensome to people who have difficulties with access to care. So if you're going to start doing this work, I really suggest simpler studies to start implementing some of these changes. The 1 or 2 visit studies are a good practicing ground, which is why I showed the study that we did in 2014, looking at vitamin D in the biopsy clinic. One-time study, 40% African-American enrollment, and I think 16% Hispanic enrollment. But it was a one visit study. I think we've kind of grown in our ability to manage clinical trials. It was not built in one day. And I think, really the only way to get around the issues with the external referrals, I believe, is to make trusting relationships with strategic partners, because I have hematology and oncology friends that are in private practice, and they don't feel comfortable necessarily always sending their patients to the big academic medical centers when they feel like they can manage it in their own practices. But sometimes it's difficult to have the latest trials in certain community offices. So it's really about kind of, if you can, building some strategic partners with people who are high volume, have minority patients, and have most of the infrastructure in place, and you can maybe build on it a little. Next. So I've had this experience several times where when I first started doing my work at Cook County, there was not a centrifuge and pipettes there to kind of prep our Buffy coat for DNA collection. That's been built up over time. Some of it we've helped to provide equipment. Some of it has been them doing it on their own, but developing this shared vision of being able to do more and more studies. So their goal was to build infrastructure to be able to do pharma trials well. And our goal was to be able to do minority recruitment in prostate cancer. So we kind of developed this parallel plan about how to get both of our kind of needs met. And they wanted to have research coordinators and maybe a research nurse. So I started to put that in the budgets so that we could have full-time and then coordinators. And then eventually we got to where we can just have part-time effort on certain grants so that we can keep it kind of always staffed. We tried to do as much as we could to deal with the fact that they didn't have certifications. We try to bring the community, the Center for Community Health in Northwestern, to some folks to allow for them to be trained with in-person visits instead of actually having to go on to the city website and get a Northwestern certification for their city training through that means. That's been working with certain community sites. The best partnership has been with Cook County Health for me. Their chair there was well trained, had a residency program that he wanted to see be able to provide opportunities for research for those folks. And in the community practices were people who just wanted to be involved in cutting edge research. They thought it was good to advertise that. And so that's who I partnered with on some of the other grants as kind of community sites. And really, it was a lot of partnership building in our initial meetings, trying to figure out a shared vision. Next. So we had several meetings to build out that vision, and it was about kind of what were the needs to get the studies done. You know, what staffing, what supplies, what storage, what refrigeration, and also we had to decide about how authorship would go. And we agreed on budgets, and we were trying to be transparent about what was included in the budgets, and started with a sense of fairness in talking about it. So I also consulted with the community sites about how I can make my research better. So I would present a specific aims page. They would tell me what's exciting about it, what sounds weak about it. And also during that time, we would oftentimes figure out what would be feasible to conduct in their sites. And that oftentimes shaped how I would format the timeline, the flowcharts of the study. Figuring out how the clinic flows, how often people kind of would follow up, how people would manage active surveillance, for example, would help me figure out how to actually, what I could actually get done in the beginning, and then they've gotten more complex over time. Next. We started to, after we talked about kind of the ideas of the type of research we would do together, I started presenting, RFAs to them and presented an initial idea. We figured out what would be needed to do it successfully there. And I helped get some of the UroNav equipment, biopsy, the right biopsy gun, the right probe tracker holders, and put that into my NIH grant budget, so that we knew up front that we were going to have that by the time this started. Of course, we paid for coordinators, but I also did a lot of other things like help format biosketches, draft letters of support, write up statements of work, and then work with their fiscal sponsor oftentimes to make sure that we were sticking to timelines. In fact, it happened with a project that Dr. Ross was working on over at Stroger. I kind of had to help monitor it to make sure that we kind of got it out on time. And so this is labor intensive. It is not always easy. And a lot of these sites are cash strapped or personnel strapped. So but we've come a long way in the time working together. Next. So really it was about building trust through regular meetings, kind of planning out our grant ideas together, and gathering whether they were interested in what idea I had, and they oftentimes helped me refine it for what they thought would make it more competitive, but also refine it for their sites to see what was feasible. And it always helped to have an understanding of what the competing studies were and how, if we needed more than one site or could we rely on just that one site. So anyway, it was a lot of conversation back and forth, and we just had to recognize that it was a two-way street, and that I had to make sure that we would have authorship kind of agreements up front. And when there was a research topic that they wanted me to support as a co-investigator or reading over their own applications for a grant, I oftentimes did that too. So, next. We're coming to the end. I think that, what can we do in our practices? Well, one thing that I saw happen was when we initially started recruiting at Northwestern for this 5 validation study, it was, around 2016, and the Affordable Care Act plans, there were about 13 of them going in Chicago. And as I realized that Northwestern was a pretty early adopter of many of them. So our Black enrollment and our Hispanic enrollment went up quite a bit on several studies for several years. And then I guess the process had become so cumbersome where each of the different Affordable Care Act plans had different kind of requirements for getting the billing in correctly. And so the hospital and many hospitals across the countries, and especially in Illinois, would stop accepting many of the plans. So I think we went from 13 plans to 6 in the course of a year. And so our African American enrollment plummeted again. So if there's a person who has a practice, that they have some control over which plan they can, accept, it may be that you can strategically look through which plans, would bring in, or popular, would bring in minorities, and have a decent reimbursement rate that you may be willing to entertain, because there are going to be a lot of ethnic minorities on those plans, and so that may be one way to get around some of the input issues. But I do think that we can prioritize rescheduling missed appointments for people who would be potential research participants, or if they have to miss it, don't make them wait another 3 months. Try and bring them back in sooner. And I think that that's a great role for the coordinators to be playing, which they have done in several studies for me. This one may be harder to implement, but having the financial counselors and billers be aware of the cost impacts. We have a study on prostate MRI, and we're going to be working with the billers, mostly at Stroger and at UIC, around which plans will accept, will authorize prostate MRI before an initial biopsy in biopsy-naive patients. So we're going to be working on that, and our team, between the doctors and the coordinators. But we would also work with the counselors to see which ones are more likely to accept it. And unfortunately, we have to make some decisions because we are definitely going to include insured people and uninsured people, but there's a limit on the number of uninsured people we can accept into this study. So we actually put into our NIH budget room for about 12 prostate MRIs a year over the 5-year grant period to get some more uninsured patients into the study. So yes, it ate into our budget, but I thought it was important because we were specifically enrolling African American and Hispanics into the study. So I needed to have some room to allow for that. Next. So, I think just when we're writing our own grants and proposals, I think if we take a little bit more seriously the inclusion of minorities and women in our planning phase when we're writing it, it would really go a lot further. I've been sitting on some review panels, and people give kind of a cursory lip service to recruitment of minorities in their studies, or they don't say anything at all. And I had the fortune of sitting on the Cancer Moonshot Biobank panel as well. And unless you are intentional about it at first, it's oftentimes an afterthought. And people will find themselves looking for samples or patients at the last minute, but they needed to have made the partnerships before the grant went out. So I would encourage people to think about partnering with minority serving sites or figuring out how they can, on their own site, really target the minorities better. One way to do it is through community advisory boards of patients. So if you have a minority patient who is grateful for the work you did with them and they want to help out in some way, oftentimes they make great readers of flyers, of study brochures to help you better target your information that you hand out to the minority populations. And so putting them on the materials so that people can relate to it has been something that I think is really helpful. And they may be able to even refer friends in who they know have their same diagnosis because people talk to others, either in support groups or just in their family and friends networks or churches, back to your clinic. So that's how they can help. And then I think you have to kind of build into the budgets a certain amount of money for uninsured participants to take effect. And the NIH has been responsive to me writing that into my grant proposals. They knew I allowed for it. We were recruiting 250 Hispanics and 250 African Americans for kind of a validation of prostate health index and prostate MRI in biopsy-naive patients. So, they saw that was a line item, and I wrote it in there, and they considered it an approach strength. Next. So I think that physicians should be asking their patients to participate, personally asking them. That's what they meant. The patients were saying was often not happening, that their providers were not referring them to studies often. And I think that's barrier number one. I think you can ask and then have a coordinator do the follow-up, but I do think that it requires this personal relationship. And then to explain the question that's being asked, maybe planting the seeds with patients in early visits by handing information about that disease or treatments or the study would be a way to, on the next time, prime them to be ready for talking about it. I also think that oftentimes minorities as African Americans are worried about giving their DNA or RNA and genetic data to people to be used indefinitely. I have had very few people refuse, but I always leave on the consent forms and discuss that they don't have to consent to let their samples be used for future research. I think it gives people comfort at the idea that they could say no. And when you want to look at your materials to see if it's actually written at a level that most people can understand and looks friendly to ethnic minorities. We have a Center for Community Health in Northwestern that has provided me with great suggestions, and they actually did a SHARP panel, which is like a focus group, to tell me how to do the recruitment using the citizen scientists. So it was a very good consultation they gave me, and they've helped me with language tailoring, recommending translators for Spanish translation as well. Next. And I just think that we all can, work on the system by being an advocate for minority recruitment. And when I was in my review panel last week, it came up several times that there was no mention of the racial breakdown of the patients that they were recruiting on renal cell carcinoma biomarkers or on prostate cancer biomarkers that they were developing. But I think that's inappropriate when there are diseases that have high prevalences in minority groups that are not really being addressed at all. I think it worsens disparities and is using public dollars to do it. So I think it's important to remind our colleagues about the importance of minority inclusion up front when we're writing it and when we are submitting to the IRB and when we are reviewing these grants. And I think that it's especially important in diseases that really do have a minority group that's at much higher risk than average. Next. I think the other thing is to encourage our ethnic minority patients to get involved in research, because it's easy to talk about the fact that disparities would widen if they did not, and that really their involvement has helped make sure that the treatments that we are coming up with are generalizable. And I encourage people to refer people from their network to participate. And you can even talk about the fact that it's important that they have insurance, because there would be out-of-pocket costs for those patients otherwise. And if you just take a minute to explain the study conceptually to patients, oftentimes they'll feel like they are returning the favor to you, I find, and also kind of furthering research in their community and improving the health of their communities. So by doing that, we're working to improve the health literacy, not just of that patient, but oftentimes a small community around these diseases, making these words like prostate and cancer kind of dinner table conversations, and not something that they only hear about in the doctor's office. And then, I would suggest that you ask your coordinators to think about barriers to participation. So if a patient says no to entry, oftentimes you would record, why did they say no? Why did they not want to participate? Sometimes it's just no time. Sometimes it's not interested in research, but sometimes it's too many visits, can't afford the parking, don't have a ride. There are sometimes that are things that we can actually address, that we've been able to offer to people, that seems to have driven up our numbers. Next. So that's all I have for you. I'll take any questions if you'd like to ask some.
Hey, Adam, this is Sean. I had a quick question for you.
Yeah.
Relative to, for example, COVID-19, which you did reference, and I know that has nothing to do with the work that you're doing, how did we do as a country in terms of recruiting, and I probably should know this better, recruiting ethnic patients towards these COVID-19 trials, and in terms of how are we doing overall in terms of dissemination of the vaccine relative to some of the barriers that you've discussed? Do you have any idea, or, because it's not obviously limited to just men who are of screening age of prostate cancer, it's for everyone. So
Yeah.
It really maybe is a good litmus test for how we're doing overall, and did we do better?
So you can look, I've looked at some of the vaccine trials, and there was quite a bit of variability in the amount of minorities that they enrolled, but they actually did better than a lot of the cancer trials, because some patients were actually being offered $1,000, African Americans, $1,500 to participate in the vaccine trials early on. It was what most people would have considered a coercive amount. But they did get reasonable numbers in many of them, but there was a really, really strong effort to do so in the COVID-19 space. There were definitely trials that were well below, but they did pretty good with elderly, with people with comorbidities, and there was a very purposeful recruitment design for a lot of the COVID-19 vaccines.
Got it. Thank you.
Hey, Adam, it's David Vanderweel. Thanks a lot. Really comprehensive, really from like small things, adjustments we could be making here to thinking globally, or like much broader, grant reviews, thinking way in advance. You talked about, I know we talked about in our GU team, and actually this is kind of related to what you just talked about the $1,000 reward or $1,500, not reward, but, coercive payments. And you talked about, including money in your grants for uninsured patients. And I think when you brought that up, you got some pushback from our clinical trials office, in the moment. I guess my question is, has this been implemented? Have you implemented this more often? Have you gotten pushback? Have you found a way to overcome that from the IRB? The fact that in general, everybody's supposed to be able to get the same compensation, or like if you can't pay for one person's MRI but have insurance cover it for a different patient, that sort of thing. You know, with people not coming from equitable situations, can you treat them, quote, unequally, whereas most of the time we frown upon that? Yeah.
Yeah, I had to have conversations with both Stroger's and Northwestern's IRB, and as you know, the SRC about it. And the head of one of the heads of the IRB at Stroger is Dr. Moulin, who was on the study that you and I submitted together, David. And the statement was the same. I said, the reality of it is that you all wouldn't, you know that we wouldn't even offer this study to an uninsured patient. Because they just wouldn't be able to afford it. So I considered it equity to basically expand inclusion to include those people.
Right.
So that was the argument that I had to use both at Northwestern and at Stroger, and I told them that the NIH obviously approved the grant this way because I explicitly wrote it into it.
Yeah, I'm wondering if there's like, well, maybe it's a moot point if the IRB's agreed with you, but obviously this is something that the NIH cares about a lot as well, and I'm wondering if we can lobby them to sort of, one, I guess, write letters on your behalf if that's needed, or two, make a statement about it that, you know, trying to treat everybody equitably is actually not equitable because they're not coming from the same place. And
Yes.
yeah.
So I remind them that equality is what they're talking about, and I'm talking about equity, which is to make everyone have the equal ability to access the same services.
Yeah.
Is just doing the same thing across the board, regardless of what their situation is. And so I call myself doing it equitably.
Yeah. Yeah. Thanks.
The NCI just actually asked for feedback last week in an email about how they can improve their diversity initiatives. And so they asked me, and I'm sure lots of people, to send them an email about kind of what we suggested, and I highlighted that fact in the email to Tiffany Wallace.
Yeah, that's great. And, you know, I'm just hearing this when we're talking about budget negotiations for trials. You know, we should be telling our budget office, we should always be asking for some money for transportation. You know, that's in the overall budget, that's going to be pennies, but if it's not there, we can't offer it. So
Yes.
yeah, that's an easy thing for us to be doing right away, I think, implement.
Yes. A lot of it is easy. There's some things easier, but you know, you're right. There's a lot.
You know, in my old cancer center in Texas, we had a benevolence fund, which was basically for just like a catch-all for people who had issues affording this or that or weren't covered, and we could dip into the benevolence fund to help them. Does Northwestern have anything like that? It would serve all trials essentially.
I don't know if that's true. That would be great if it was. I mean, I know about Northwestern has charity care, right? But I don't know about like for trials. Each time I've had to write for, you know, bus cards and parking passes for every study I've ever written, and I just put it in the budget. But it would be great if that were.
Yeah, I think a few things. One, first of all, thank you again for speaking tonight, particularly going into a long weekend. It's really appreciated. Two, I've learned two things solidly from you about minority recruitment, you know, from what you've done and from this talk, which is, you know, you have to plan ahead, budget it, make strong partnerships, and be thinking about, like you said, you know, equity, not equality, and making sure you're reaching everybody. And the third thing, I think it is something, MK, as we talk to donors and whatnot, I think that it is an area we can really think about is, should we have a benevolence fund? Because sometimes unforeseen costs come, depending on who did your budget, they're not very flexible. And then you don't want to have protocol deviations or people drop out just because, you know, they couldn't, you know, make the $50 to make a couple car trips or not to fit in. But really great talk, Adam. Really appreciate you being here.
You're welcome. We did negotiate with radiology at both sites on a fixed cost per MRI for research. And it's a protocol, whatever protocol you ask them to do for it has a specific cost, and that's what we put into the MRI budget, into the grant budget. Anything else?
Well, thanks a lot, Adam.
Thanks, Adam.
Thanks so much. Thanks, everyone. Have a great holiday weekend.
You all too, and thanks for the invite.
Thanks, Adam. Appreciate it.
You're welcome.